Sorry, Tejo, I'll make you the host. And please make me the co-host. So, Tejo, can you see my slides?
Yes, sir.
Yeah. So thank you. Is the voice clear?
From my side, it's clear.
Okay. So thank you. And my topic for today and the starting topic is oxygenation and its relevance in neonatal disease. I'm sure why this topic has taken the precedence, because 80 to 90% of neonatal diseases are relevant to how do we oxygenate babies? How do we ensure that the oxygen from the air goes to the lungs and the oxygen from the lung reaches the tissues? So in this topic, I would try to cover these under these subheadings. That is ventilation, which involves how do we move the oxygen from the air. Air has oxygen, 21% oxygen, and this oxygen we need to move to the lung. And once it reaches the lung, by diffusion, the oxygen will move from the alveoli to the pulmonary blood. So we'll learn about that aspect. And from the pulmonary blood, so from the pulmonary arteries, the blood has to move to pulmonary veins and there into the heart, and from there to the tissues. So we'll learn about perfusion. And then once it reaches the tissues, the oxygen from the blood has to reach to the tissues. So again, by a process called diffusion, and we'll learn about that process too. And then lastly, we will see how in the tissues, oxygen reaches the mitochondria, and in the mitochondria, what role oxygen has to play. So in this sequence, we will try to touch each one of these aspects, and please post your questions in the chat box if you have any. So you can see here, the oxygen has to come from atmosphere. When we breathe, the oxygen goes to the nasal passages from the airways into the lungs. And when we breathe, the oxygen concentration in the air is 21%. That is a fraction of oxygen in the air is 21% or 0.21. And if you multiply by partial pressure of oxygen, or if you imagine we are at a sea level, the partial pressure of air in the sea level is 760 mm of mercury. That is a pressure of air, and out of which 21% is oxygen. So 21% into 760 is 160 mm of mercury. So the gas which we breathe daily has, so when you are inhaling at the nose level, the oxygen level is 160 mm of mercury, or if you convert into percentage, it is 21%. And this gas, when it goes to the airway, that is into the trachea and in the airway, the partial pressure of gas in the air, in the trachea, is partly occupied by the water vapor. So the 21% of oxygen remains the same. So the pressure in the air is 760 minus the water vapor pressure, which is about 713. So that pressure of air in the trachea, 21% is contributed by the oxygen. So from the air, when it comes to the trachea and the airway, the partial pressure of oxygen is 150 mm of mercury. So this 47 is the water vapor pressure, which is there in the airways. So from here, from the airway, the gas will go to the alveoli and remains at 150 mm. So in the alveoli, there is a partial pressure of oxygen which is occupied. The partial pressure is also occupied by the carbon dioxide. Now the partial pressure of carbon dioxide is 40, and we divide it by the respiratory coefficient when you're taking a balanced diet. When you're taking a balanced diet, the partial pressure of carbon dioxide which is produced in the body is 40, and that comes into the lungs, into the alveoli. So the partial pressure of oxygen in the airway was 150, because when it comes to the alveoli, part of it is occupied by the carbon dioxide. So the partial pressure of oxygen in the alveoli is 100 millimeters of mercury. So in the air, it was 160. In the airway, it becomes 150 because part of it is occupied by the water vapor. And when it comes to the lung, carbon dioxide occupies part of this pressure. So in the alveoli, the partial pressure of oxygen is 100 millimeters of mercury. Now from the alveoli, it has to go to the blood. And there is a difference of partial pressure from the alveoli to the blood. And this is because there is a barrier between the alveoli and the blood. This barrier is contributed by the alveolar membrane, interstitial tissue, and the alveolar endothelium. So since this barrier is there between the alveoli and the blood, the partial pressure of oxygen drops from 100 to 70 mm of mercury from the alveoli when it reaches the blood. So you expect the partial pressure of oxygen in the blood in newborn babies is 70 mm of mercury. So there is a difference of partial pressure from the alveoli to the blood, and this is the AADO2. The difference in alveolar to arterial difference of oxygen is nearly 30 mm of mercury difference in newborns. But this difference may be about 10 mm in the adults. So in adults, you will get a PaO2. P arterial oxygen could be about 80 to 90 mm mercury, because in the alveoli it is 100 and most of it reaches the blood in adults, but only 70%. That is, there is a difference of 30 mm difference between the alveoli and the blood. To reach from the alveoli to the blood, there is a diffusion barrier, and that is causing the drop in partial pressure from 100 to 70 when it reaches the blood. Now from the blood, this partial pressure has to go across the tissues. In the arterial side, the oxygen partial pressure is 70, and on the venous side, the partial pressure is 40. So this pressure drops from 70 to 40 because part of the oxygen will be utilized by the tissues. So the tissues draw the oxygen from the blood, and that is why the partial pressure of oxygen is the diffusion from the blood. It diffuses into the tissue, and it is a partial pressure which will ensure that the gas diffuses from the blood to the tissues. So once the oxygen diffuses into the tissues, the partial pressure of oxygen becomes from 70 to 40. And in the tissues, in the mitochondria, so the partial pressure of oxygen in the tissues could be less than 40, and from there to the mitochondria, which is there in the cells, the partial pressure could be as low as 1 to 3 mm of mercury. So you see that from 150 partial pressure of oxygen in the atmosphere till it comes to the mitochondrial level, 160 becomes only 1 to 3. And all our organs, the lung, the blood, the hemoglobin, and the tissues are working to ensure to get this 1 to 3 mm of mercury pressure of oxygen in the mitochondria, because it is a mitochondria which is a storehouse of ATP, and ATP production is dependent on oxygen. With oxygen, we produce about 36 ATPs, and without oxygen, this production becomes only 2. So mitochondria will work the best in the presence of oxygen, producing 36 ATPs for 1 carbohydrate use, whereas it produces only 2 ATPs in the absence of oxygen. And that could lead to lactic acidosis and other problems for the entire body. So our body is trying to push this oxygen from atmosphere till the tissues, till the mitochondria. All this is working in a coordinated way to ensure that the ventilation takes care of getting the gas from the atmosphere to the alveoli, diffusion takes care from alveoli to blood, perfusion takes care from the pulmonary artery to the tissues, and at the tissue levels, again, diffusion takes care from blood coming, oxygen coming from blood to the tissues. So that is what based on the partial pressures. So how much oxygen comes from the air till the tissues? So that is the volumes. And to get the oxygen from the air to the lungs, we have to have the concentration and the tidal volumes and the rate. These are the 3 parameters which will ensure that atmospheric oxygen is coming to the lungs. So if you have more concentration of oxygen in the air, more oxygen will go to the lungs. Concentration of oxygen is decided by the fraction of inspired oxygen. So we want more oxygen in the lungs, we can increase the inspired oxygen concentration. That is what we do when you use CPAP or oxygen by nasal prongs or by ventilation. So we improve the concentration of oxygen in going to the nose so that more oxygen goes to the lungs. So one method of improving oxygenation is increasing the concentration of oxygen in the air or in the which we breathe. The second thing is, if the concentration remains the same, then increase the amount of gas going into the lungs from the air. That is, every breath which take, you increase the tidal volume. So you take a deep breath so that more gas goes into the lungs. Concentration is same, but more gas is going into the lungs so that there is more gas available for exchange from the alveoli to the blood. That is the second method to improve oxygenation into the lungs. The third method is increasing the rate. So when you breathe more fast, more amount of gas in 1 minute goes into the lungs and more amount of gas is available in the alveoli for exchanging with the blood. So the three methods we can improve the oxygen from the atmosphere to reach the lung is improving FiO2, improving the tidal volume, and improving the rate. And all this will lead to improve oxygen in the alveoli. So from the alveoli to the blood, if you want to improve the amount of gas exchange, so that is from the alveoli, the blood has to go into the blood. So the oxygen has to go into the blood. So that means the alveoli should remain open. How do we keep the alveoli open? By taking a deep breath if you're doing manual breathing. But if you're using a ventilation, you bring the lungs to at functional residual capacity, which means it is at the volume of the lungs. It is the optimal volume of the lungs at which the blood vessels are open and the alveoli are open. This is called FRC, functional residual capacity. It is the volume of lung mostly at the end of inspiration. So that is the residual volume becomes a functional residual volume when you inflate the lung and open up the capillaries around. So to ensure that we get the alveolar oxygen coming to the tissues or from the pulmonary arteries, we need to improve the FRC. And if you are ventilating using CPAP or ventilation, you need to improve the mean airway pressure. You improve the pressure which you're pushing into the air and into the alveoli opens up. The collapsed alveoli open up with the pressure and there is more volume of gas exchange between the alveoli and the blood on the other side. So the method to push the gas or oxygen from the alveoli to the blood is improving the mean airway pressure or functional residual capacity. And from once the gas reaches the blood, from the blood it has to reach to the tissues. And what helps that? It is the cardiac output and the hemoglobin. So from the pulmonary arteries, the blood needs to reach the tissues. To push the blood, the oxygen from the pulmonary artery to the tissues, you have two methods. One is the cardiac output, which is helping in pushing the blood, which is helping in perfusion. And what carries the blood? Blood is carried in the oxygen is carried in the blood by two methods. One is the hemoglobin, the other is dissolved form in the blood. So hemoglobin carries maximum amount of oxygen from the pulmonary artery to the tissues. Most of the oxygen which we breathe is carried from the capillaries, pulmonary arteries to the blood using hemoglobin. Only part of this oxygen dissolves in the blood, and that dissolved oxygen is also carried from the pulmonary artery to the tissues. So the perfusion is the thing which pushes the blood from the pulmonary artery to the tissues, and it is a hemoglobin which carries the oxygen from the pulmonary artery to the tissues. And at the tissue level, the blood has reached the tissue, but how much oxygen from the blood will go to the tissues depends upon the tissue demand. So more demand, the oxygen coming, more of it will be extracted. So there will be more difference between the oxygen coming to the tissue and oxygen leaving to the tissue. If the tissue demands improves, the saturation of gases which is coming to the tissue and saturation of gas which is leaving the tissue, the difference will increase because more demand, more oxygen will be taken from the blood by the tissues. The second thing is there is a concept of regional blood flow which is coming up, which says that in a difficult condition like shock, the blood flow to the brain improves, compromising the tissues like gut, kidneys, and the skin. That is why in shock, you will see decreased peripheral circulation, decreased gut motility, and decreased urine output. But mentation is maintained because the blood is being pushed to the brain so that more and more oxygen go to the brain, and the vital organs like brain and heart get supplied, compromising the other organs whenever there is a deficit of oxygen, whenever there is a deficit of blood flow to the tissues. So regional blood flow will also ensure that the tissue supply of oxygen is maintained to the vital organs. The other most important component which delivers the oxygen from the blood to the tissues is based on oxyhemoglobin dissociation curve. So the delivery of oxygen from the blood to the tissues or from the blood to the mitochondria is based on the oxygen dissociation curve, which we'll discuss in the next slide. So to get the gas from the air to the lungs, we need to have proper ventilation. We need to improve the concentration of oxygen, improve the tidal volume and rate. From the alveoli to the capillaries, pulmonary capillaries, if you want to make the blood go, the oxygen go from alveolar to capillaries, you need to improve the surface area of exchange. you need to open up the atelectatic lungs, and you need to open up the capillaries along the alveoli by improving the optimum MAP, mean airway pressure. To make the blood, the oxygen move from the pulmonary capillaries to the tissues, you need to have adequate amount of hemoglobin, which carries the oxygen, and we need to have a good perfusion to make the blood move from pulmonary capillaries to the tissues. At the tissue levels, if the tissue demand improves, the more oxygen extraction occurs, and based on the oxygen dissociation curves, which gets altered at the tissue levels, more of oxygen which is there in the blood gets converted to the tissues. So these are the concepts which we need to understand, how oxygen is going to the tissues and into the mitochondria. So to improve the oxygen delivery, overall we can improve the fraction of inspired oxygen, we can improve the tidal volume and rate, we can improve the mean airway pressure so that the collapsed alveoli open up, the capillaries which are closed open up, and we can improve the cardiac output to improve the tissue oxygen. We can improve on the oxygen, hemoglobin, to ensure that more oxygen is bound to hemoglobin and that oxygen goes to the tissues. And at the tissue level, we can make the oxygen in the RBCs to reach the tissue by shifting the oxygen dissociation curve to the right. And how that happens, we'll discuss in the subsequent slide. We can also alter the tissue demands and regional blood flows to ensure that the vital organs get the blood supply, and especially when they are compromised. So we can alter the tissue blood flow to ensure that more oxygen goes to the particular tissues. And now people are thinking of some conditions where you can preferentially improve the blood flow to the gut, to the kidneys, in special conditions, so that the compromise to these organs can be decreased. So we'll go one by one. How do we improve the fraction of oxygen which we breathe? And what we breathe has 21% oxygen, that is FiO2 in the room air. We can improve. If you improve the concentration of oxygen, more of oxygen will go to the alveoli, and thereby more oxygen will go to the blood. Now, whenever you're using CPAP, we do not want to increase the concentration of oxygen going to the lung more than 30%. If it is more than 30%, we understand that CPAP may not be adequate to open up the lungs and to get the oxygen from the lung to reach the tissues or to the capillaries. So on CPAP, we try to avoid oxygen concentration more than 30%. When we ventilate, we use slightly more pressures and slightly more concentration of oxygen we allow. But in a normal conventional ventilation, we try to avoid FiO2 more than 60% of oxygen going into the lungs. Whenever you use high frequency ventilation on in very sick babies where it is difficult to ventilate, sometimes and rarely we may go up to 100% oxygen, but 100% oxygen is mostly avoided in most of the neonatal diseases. So by increasing the concentration of oxygen which is going into the airway, we are increasing the PaO2 only. And this will happen only when the lungs are diseased. So suppose you are pushing more concentration of oxygen into the airway without opening of the lungs, this gas will not go to the tissues. So if there is a lung disease, then improving concentration will help in improving gas going from the alveoli to the blood. But the lungs are already open, but the capillaries are not open. There is no blood flow across the lung. Whatever concentration of oxygen you increase, that gas will not go to the blood, and that is what is called shunt. So when you open up the lung, give more oxygen, but the PaO2 is not increasing, means there is a shunt. The blood is flowing across or away from the lung, and blood is not getting oxygenated in the lung. So that is what is called shunt. If you have shunt, improving the concentration of oxygen or improving the lung volume, increasing MAP is not going to improve the blood oxygen levels. So how much of oxygen goes? So these numbers you can remember. Normally in a newborn, the minute volume is 0.2 to 0.4 liters per minute. And the amount of oxygen the newborns breathe is 21% or 0.21. And the amount of oxygen which is expired by the baby, the expirator gas has 0.17 concentration of oxygen. So you see that 0.04% or 4% of oxygen is used by the baby for the tissue demand. So oxygen from air to blood per minute, I said around 200 to 400 ml of oxygen air is going into the lung per minute, out of which, so I've taken the median of that 0.3 liters per minute, which is 300 ml per minute. And we said 4% of the air which you are breathing is utilized by the body. What is going in is 21%, what is coming out is 17%. So 4% is lost. So that 4% is going into the blood. So that is 0.04 ml or 4% is 0.04. 300 ml is what we breathe per minute, or the newborns breathe per minute. That means 12 ml per kg per minute of oxygen is going to be taken by the baby per minute. So from the air into the blood, normal baby takes approximately 12 ml per kg per minute. And this 12 ml per kg per minute has to reach to the tissues. So if you know the tidal volume, if you know the rate, you can calculate the minute volume. And if you know the percentage of oxygen the baby takes in and the percentage of oxygen which is coming out, you can actually calculate how much of oxygen baby is utilizing per minute. Whenever there is no breathing, whenever baby does not breathe, the gas from the atmosphere does not go into the lungs. This is called hypoventilation. If there is hypoventilation, the only way we can improve the oxygen going into the lung is ventilate the babies. That means you make the oxygen go in and out of lung by using artificial methods like ventilation. So in a baby who is asphyxiated, who have a serious CNS injury, the reason for hypoxia is decreased ventilation or decreased, the hypoxia is because of decreased ventilation or decreased breathing. And there, the only methods you can improve the oxygen going to the lungs is by improving the tidal volume and by increasing the rate. So you ventilate those babies. Hypoxia, one of the reasons for hypoxia is hypoventilation, which occurs in asphyxia or in babies who are CNS depressed. And in those babies, you have to artificially ventilate to provide the tidal volume, to provide the rates. You need not improve the concentration of oxygen. So the second way we can improve the oxygen going from the alveoli to blood is improving the FRC or improving the mean airway pressure. FRC allows a continuous diffusion of gas from the alveoli to the capillaries. So if you improve the volume of exchange by using pressure, the lung volume improves. And as the lung volume improves, the gas from the alveoli will diffuse to the capillaries, which are on the opposite side. When you use the pressure, it is like opening a crumpled blood sheet. If a bed sheet is crumpled and one side you have oxygen, the other side is capillary, by using pressure, you open up the crumpled bed sheet. This will ensure that the gas on one side is able to reach the other side where capillaries are there. So you're using this pressure to open up the alveoli which are collapsed, or the crumpled alveoli are opened up. You're improving the area of gas exchange by using the pressure into the lungs. So, and this pressure you use only when the alveoli are collapsed. So increasing MAPS results in improving the area of gas exchange. More gas flows from the alveoli to the blood because the gas area of exchange increases and the diffusion becomes better by using mean airway pressure. So good diffusion, good MAP reduces the breathing rate. Once your baby is able to oxygenate better, his tidal volume. Okay, so using high MAP or high FRC may counterproductively cause hypoxia again. So when you overinflate the lungs, the capillaries around the alveoli again collapse. And this can cause problems in ventilation again, because when you overinflate, the capillaries close up and there will be a dead space ventilation. The gas is going into the lung, but not into the blood. That will happen hypoxia. That is the reason for hypoxia and PAH. And when you use high pressures, the alveoli over distend. So this is what happens in the alveoli. So if you have a collapsed alveoli, you can open up the collapsed alveoli by giving pressure. When you give pressure, the alveoli open up. And if the alveoli open up, the gas from the alveoli will go to the blood. And this deoxygenated become oxygenated blood. What is the way to open up this alveoli? By increasing pressure or bringing this alveoli to functional residual capacity. In PPHN, the blood is flowing across the alveoli which are collapsed, or the blood is not able to flow across this blood in the capillaries. So because the capillaries are collapsed in PPHN. So whatever you are giving excess oxygen into the lungs, this oxygen will not go to the blood and hence oxygenation will not improve. So PPHN is a type of shunt. So in shunts, improving oxygen concentration will not improve the oxygen in the blood. So this is called VQ mismatch. So dead space ventilation, when the alveoli are open but blood is not flowing, this is dead space ventilation. And collapsed alveoli, when alveoli are collapsed but blood is flowing, this is in atelectasis, there is no gas exchange. These two phenomena are called VQ mismatch. So whenever there is VQ mismatch, the oxygen from the alveoli will not be able to reach the blood. And this is the commonest reason for hypoxia in the newborn. Hypoventilation, where you are not able to breathe or baby CNS is depressed. And the second reason, whenever there is a lung disease, you have either atelectasis or dead space ventilation, which will lead to VQ mismatch. And that is the commonest reason for hypoxia in the newborns. And the third reason is shunt. which is not in the lung, but away from the lung. This is a right to left shunt which across the PDA and across the atrial septum, which the blood flowing from right side to left side, bypassing the lung, that is shunt. And whatever oxygen you give into the lung, whatever you inflate the lungs, the gas does not reach the blood because the blood is being shunted across the PDA or across the ostium secundum or OSD. So that is what happens in shunts. So improving lung condition or improving the oxygen concentration will not help shunt diseases. So here you can see the third problem in the lung is, one, we talked about dead space ventilation, we talked about atelectasis, we talked about shunt, which is shunt is not related to the lung, but sometimes the blood is there in the alveoli but not reaching the blood. That is because the barrier between the alveoli and the blood is widened. This occurs rarely in conditions like TTNB or in conditions like alveolar capillary dysplasia. You will see that the alveoli got thickened. So oxygen is going to the alveoli but not into the blood. So this is another common reason for hypoxia you see in the newborn, that is TTNB. So, but the commonest cause of hypoxia is VQ mismatch. Following this will be the TTN, like what you see in TTNB, and following but hypoventilation, and lastly shunt. So in that order, these are the 4 reasons for hypoxia, tissue hypoxia or hypoxia in the blood in newborns. So now when you open the lung, there is an optimal volume at which the blood into the lung is perfusing or diffusing into the capillaries on the opposite side. So when the lungs are collapsed, the gas doesn't reach the lungs, so the gas doesn't go to the alveoli. When the lungs are optimal open, the gas comes to the alveoli, goes to the opposite side of the blood. When the lungs are over distended, again the capillaries are collapsed, the gas comes into the lungs but does not go into the blood. So likewise, there is a U-shaped relationship between the pulmonary vascular resistance, that is the blood flow into the lungs, versus the blood which is the gas which is in the lung. So at FRC, at optimal volume of the lung, the PVR is the least. When the lung volume increases, your PVR increases. When the lung volume decreases, your PVR decreases. So in hyaline membrane disease, RDS, your PVR is going to be higher. In meconium aspiration syndromes, again, as the FRC increases or the lung expands, your PVR increases. So in meconium aspiration and in RDS, you have hypoxia partly because PVR is also high. So ideally, when you open up the lung, you should ensure that you keep the lung at FRC, whether it is in CPAP or whether it is in ventilation. When you keep the lung at FRC, the optimum ventilation or optimum VQ matching occurs. How do you know that the lung is at FRC? When the baby does not have subcostal intercostal retractions, whether it is on CPAP or whether it is on ventilation, you know that the baby is at FRC, and that FRC is the FRC where VQ matching is ideal. So when we increase the pressures, when we increase the CPAP in CPAP, or when we increase the PEEP in ventilation, we are bringing the lung to FRC to ensure VQ matching. So PVR is least at FRC. So you can see here PVR is higher and RDS lung, and PVR is also going to be higher in meconium aspiration lungs. In TTNB, the reason for hypoxia is, one, that gas is not going into the lungs because of atelectasis, and second reason there could be that the diffusion barrier between the alveoli and the capillaries, there is a gap because interstitial edema is there in TTNB. So you can see the interstitial fluid here, and that may impair oxygenation in TTNB. In TTNB, one of the reasons for hypoxia is diffusion deficit. The classical example where diffusion deficit is the reason for hypoxia is alveolar capillary dysplasia. So whenever there is a true shunt, that means blood is flowing extra lung, that is through the PDA or ostium primum, whatever concentration of oxygen you are increasing, the PaO2 does not rise. So you can see here in this graph. So here you have 3 lines. One is the red line where you have shunt, that is the true shunt is only 10%. The second line where the true shunt is 30%. The third line when the true shunt is 50%. That means 50% of blood is not going into the lungs. In the last line, in the middle line, only 70% of the blood is going to the lung, 30% is crossing the lung or bypassing the lung. In the first condition, 10% is bypassing the lung. So in these conditions, you can see that when you increase the FiO2, you will get increased PaO2 only when the shunt is 10%. But in the conditions like RDS, where 30% is the shunt, when you increase the FiO2 beyond 30 to 40%, as you increase FiO2, you will see increase in PaO2s. And the last condition where the shunt is almost 50%, like in PPHN, whatever FiO2 increasing, you won't see a change in the PaO2. So when you increase the FiO2 in lung diseases, when you are ventilating, when you increase the FiO2, there is no change in saturation, there is no change in PaO2s, you can assume that there is a significant portion of shunt, and you should improve the shunt capacity by using inotropes or by using specific medications for PPHN to ensure that the gas from the alveoli goes to the blood. So here you can see a baby who is having RDS, which has atelectasis, which could be having 30% shunt. And here we will improve the lung capacity by improving the concentration of oxygen, by improving the MAP and FRC. And here you have a lung which is having hyperinflated. So that means the gas is able to go to the lungs, but will not be able to reach the tissue to the pulmonary artery. So here you will try to alter the PVR by opening up the lung, by using the optimal PEEP and avoiding over distension, and also working on improving the PPHN or shunt. So the third component, that is from the blood, the gas has reached the blood. From the blood of pulmonary capillaries, it has to reach the tissue. And for this, you have to remember two important things, that is the cardiac output and hemoglobin. We said 12 ml per kg per minute of gas or oxygen is going from the air to the pulmonary capillaries per minute. So if your normal cardiac output is 240, this is the cardiac output in newborns, 240 ml per kg per minute. The newborn normal cardiac output is 240 ml per kg per minute. And oxygen is the one, the hemoglobin is the one which transports oxygen from the tissues, from the lungs to the tissues. So oxygen transport in 1 minute from the pulmonary capillaries tissues, we can calculate this. So I have shown you the volume of blood which is there reaching from the pulmonary capillaries to the tissues per minute is 240 ml per kg per minute. So that is a cardiac output. And we know that from the capillaries, the oxygen is carried to the tissue by hemoglobin. And how much hemoglobin carries oxygen? If hemoglobin is 100% saturation, is saturated, 1 gram of hemoglobin carries 1.34 ml of oxygen. So if you have 1 gram of hemoglobin, 100% saturated, it carries 1.34 ml. So the cardiac output, the amount of blood moving from the pulmonary capillaries to the tissues is the cardiac output. And in that, per 100 ml, how many grams of hemoglobin is the concentration of hemoglobin, and 1 gram of hemoglobin carries 1.34 ml of oxygen if it is 100% saturated. And the rest, there is a small amount of oxygen which is coming from the alveoli to the blood, dissolved in the blood, and that is 0.003 ml per 1 mm of mercury of PaO2, which is the partial pressure of oxygen in the pulmonary capillaries. So to calculate this, cardiac output is 240 ml per minute per kg. Normal hemoglobin is 15 grams. And let's assume that we are having 97% saturation. That means if the saturation is 97%, probably it will carry 1.33 ml per gram of hemoglobin. So this is what it will be, amount of oxygen carried by the hemoglobin at 97%. So 15 grams of hemoglobin will carry 15 into 1.34 into saturation, because 0.97, not 100%. So it may be around 1.3 into 15. This is the amount of oxygen which will be present in the hemoglobin. And since 100 grams of 100 ml of hemoglobin, 100 ml of blood has 15 grams of hemoglobin, that much will be the, if you multiply this with the volume, you will get the amount of oxygen carried to the tissues. We will do in the next step. And 0.2 ml is the amount of oxygen dissolved in the blood, which is minuscule compared to amount of oxygen carried by the hemoglobin. So this is the amount of oxygen in the blood per 100 ml of blood. 19.5 ml of oxygen is there if your hemoglobin is 15 gram per deciliter with 97% saturation. And since it is 19.5 per 100 ml, for 240 ml, that is 240 ml, it will be 19.5 into 2.4 will be the amount of oxygen will be carried from the pulmonary capillaries to the tissues per minute per kg. And 0.2 ml per deciliter will be what will be carried, dissolved in the oxygen. So you can again calculate here, you can see that cardiac output is 2.5 ml. As I said, 15 gram into 0.7 into 1.3 plus this 0.012 because we have multiplied with 70 as the arterial and the venous side. So in the venous side, the saturation is 70%. So the amount of oxygen in the hemoglobin on the venous side will become from 97 to 70%, which is hemoglobin remains the same. So this multiplication, if you do, you will get 14 ml per deciliter of oxygen in the venous side. So how much has gone to the tissues? 19.5 minus 14, which is 5.5 ml of oxygen has gone from arterial side to venous side per deciliter of blood, which has gone to the tissues. How much has gone to the tissues volume? 240 ml. Per 100 ml, you have 5.5 ml. For 2.4, so 240 ml it is 2 into 2.4 will be the amount of volume of oxygen carried from the pulmonary capillary to the tissues. If you multiply all this, it will be coming as 12 ml per kg. So you see that whatever has reached the capillaries, that much is going to the tissues based on the cardiac output, based on the arterial oxygen content and the venous content. So these calculations you can go back and do again yourself to see that exactly what oxygen you're breathing is going to the tissues or not. So last point from the, so to get the oxygen from the lung to the blood, we need to improve the ventilation or improve the concentration of oxygen, and to get the oxygen from the capillaries to the tissue, we need to improve the cardiac output, and to improve the quantity of oxygen which goes from the pulmonary capillary to the tissue, we need to improve the hemoglobin content. So which of them are important? If you see here, when you're breathing in room air, your oxygen is 21% PaO2. This is coming in pascals. Don't worry about this, but 6. Saturation is 75% in the room air, and hemoglobin is 8 grams. And this is baby's hypoxic, so his saturation is 75%. And dissolved 1.3 per 100 ml. And this is the amount of content of oxygen in the blood. So this is because 8 grams per deciliter or 80 grams per liter, and into 1.4 become 83 ml of oxygen is there per liter of blood, and saturation is 75%. So how do we improve this oxygenation? So we can improve the FiO2. So when you improve the FiO2, you have just improved the FiO2. So what happened? The saturation improved from 75 to 93%. So the amount of carbon oxygen content in the blood has increased from 83 to 103. So change is 24. From 83, it has become 103. The percentage change in oxygen which is going to the blood is 24%. On the other hand, if you increase the concentration of oxygen from 35 to 60%, here, you can see here that saturation has gone from 93 to 98%. However, the content of oxygen is increased from 103 to 110. So by increasing, almost doubling the concentration of oxygen, you could not get further increase in the content of oxygen in the blood. But since the hemoglobin was low, so your hemoglobin was only 8 grams, you increase the hemoglobin to 12 grams. Now what happened? With the same FiO2 of 60%, when you increase the hemoglobin, your content of oxygen increased almost doubled. So from 110, it becomes 104. So, and it is improved by 48%. So if you look at the way to improve the tissue hypoxia, the prime thing is first improve the circulation, second improve the hemoglobin, next improve the concentration, in that order. If tissue is hypoxic, first improve the blood flow, improve the concentration of hemoglobin, and last improve the concentration of oxygen or improve the content of oxygen coming from the airway to the blood. So this is the concept which you have to learn when you are ventilating or when you have a problem with oxygenation. So the last component is shown here. Increasing perfusion gives the best dividends. So improving perfusion gives the maximum improvement in oxygenation, followed by improving hemoglobin, followed by increasing FiO2 and or improving the mean or ventilation. So if there is a tissue hypoxia, always try to remember that you need to improve the perfusion, then hemoglobin, then ventilation, then fraction of oxygen. In that order you should go based on the problems you see in the baby. So from oxygen from blood to the tissues, it is based on the diffusion, and once the blood reaches the tissue, from the blood tissue, it has to go in, from the blood, it has to go into the tissues. And this is again concentration gradient. So you have about 70 mm here, and in the tissues, it can be less than 40. So the blood from the oxygen from the blood will go to the tissues because of partial pressure drop from the arterial side to the venous side and partial pressure drop from the artery to the tissues. the blood oxygen will diffuse from the blood to the tissues. So as tissues consume oxygen, as the tissues consume oxygen, their metabolism increases. So the temperature increases, their CO2 goes up, and the ATP becomes ADP. When the tissues use energy, ATP becomes ADP. So whenever tissues, the blood is reaching the tissues, at this level, the temperature of the gas is higher. There is acidosis because the tissues are metabolically active. There is production of carbon dioxide because tissues are consuming oxygen. And there is increased 2,3-DPG because tissues are using oxygen and metabolism goes up. The levels of 2,3-G goes up. This point is important because this is going to help the delivery of oxygen from the RBCs to the tissues as the oxyhemoglobin curves shift to the right. Shifting of curve to the right occurs because of increased temperature, because of acidosis, because of increased carbon dioxide and increased concentration of 2,3-DPG, which all occur at the tissue level because of metabolism. So tissue oxygen less than capillary oxygen. That is why from the capillaries, the gas will diffuse into the tissue. As PO2, as the dissolved oxygen decreases in the capillaries, the blood from the hemoglobin will diffuse from the hemoglobin to the capillaries. So that is why there is a drop in PaO2 from the arterial side to the venous side. You will see that the drop in PaO2 is from 95 to almost 40 mm, as the gas from the blood will go to the tissues, the gas from the RBCs will come to the blood, and the concentration or the saturation of gases in the RBCs will decrease from arterial to venous side, and the PaO2 will drop from arterial to the venous side as the gas diffuses from the tissues to the from the capillaries to the tissues at the tissue level. And this offloading of oxygen from hemoglobin to the blood will be precipitated because the tissues are metabolically active, and as the metabolically active tissues shift the curve to the right. So this is the oxygen dissociation curve, which you have to understand. You see that the red line is the line of the oxygen dissociation curve when the gas is reaching the tissue arteries or capillaries. At the venous side, you can see here that the gas as the oxygen dissociation curve is shifted to the right side. So that means at the tissue level, the curve is shifting to the right. When the curve shifts to the right, at the same PaO2 levels, the amount of oxygen which is present in the hemoglobin will be lesser when the curve shifts to the right. So the hemoglobin will have more oxygen at the starting of the tissues, and as the tissue starts metabolically active, the curve shifts to the right. So from the oxygen from the hemoglobin will start going from the hemoglobin to the blood because it starts offloading. Its ability to hold oxygen decreases as the curve should shift to the right at the tissue level. So this shifting of curve to the right at the tissue level helps in offloading of oxygen from the hemoglobin to the blood, and that will help the oxygen from the blood to reach the tissue much more effectively as the tissues are using more and more oxygen. At the lung level, the curve shift to the left, and I'm sure Deepak is going to help you to understand why the curve shift to the level, oxyhemoglobin curve shift to the level at the lung side. And at the lung side, the ability to hold oxygen goes up in the lung. So more of oxygen will be extracted from the lung into the hemoglobin at the lung level. At the tissue level, the same hemoglobin gives more oxygen to the tissues, although PaO2 is same. So I hope you understand this. Shifting of curve to the right will help in offloading of oxygen. Shifting of curve to the right will help in offloading of oxygen to the tissues, and shifting of curve to the left will help in more oxygen being carried by the hemoglobin, which will occur at the lung level. So the oxy dissociation curve will help in offloading of oxygen from blood to the tissues, and this occurs at the tissue because of acidosis, because of decreased pH, increased temperature, increased 2,3-DPG. It also happens, the shift curve shifts with fetal hemoglobin. That means the ability of oxygen offloading to the tissues is lesser with baby hemoglobin or a premature hemoglobin than with the adult hemoglobin. So when you give adult hemoglobin, the delivery of oxygen to the tissues improves because fetal hemoglobin does not give off oxygen easily, because the curve of fetal hemoglobin is to the left compared to the curve of hemoglobin of adult, which is to the right. So if the curve is right, offloading is better. If the curve is to the left, gaining of oxygen by hemoglobin is better. So all the conditions, reverse condition will lead the curve to shift to the left, which happen at the lung level. So oxygen from the tissues reach to the mitochondria. What happens to the oxygen in the mitochondria? In the mitochondria, oxygen is used for ATP production. And in the cell of the mitochondria, it is used for synthesis of substances, regulation of ion channels, that is the sodium potassium pump. It is used for multiple enzymes which are used in the cytoplasm of the mitochondria and for genetic modulations in the mitochondria. It's also used for free radical generation whenever oxygen levels in the mitochondria go up. So in the absence of ATP production, if the mitochondria does not use oxygen, there will be increased lactate. So that is why tissue hypoxia will lead to increased lactate levels. And whenever oxygen levels are less in the cell of the mitochondria, you can have low blood pressure because some ion channels are disturbed, some enzymes are disturbed. Mainly the dopamine or epinephrine synthesis is defective whenever the oxygen levels are less in the tissue cytoplasm. You could have more of PDA and hypotension, and you could have chronic lung disease because there is more free radical generation whenever there is more oxygen coming to the mitochondria. So the energy pump, that is the sodium potassium pump, is ATP dependent. If this is not working, there will be anaerobic metabolism and lactate production, and electrical potentials if there are depolarization, opening of ion channels, activation of receptors, influx of calcium, all this will be energy regulated, and that will lead to pseudo metabolism in the cell, which leads to tissue hypoxia and cellular hypoxia and lactate production and other problems. So look at, there are so many enzymes which are dependent on oxygen, and there are concentration of oxygen is also at which the enzymes get defective is shown here. You can see glucose oxidase is dependent on oxygen. Xanthine oxidase, which is a free radical scavenger, is also dependent on oxygen in the tissue. Tryptophan oxygenation is dependent on tissue, mitochondrial oxygen levels. Nitric oxide, which is a vasodilator, is dependent on tissue or mitochondrial oxygen levels. Tyrosine, which again is a enzyme in production of epinephrine, dopamine, dobutamine. Again, if oxygen is not reaching the tissue, this could be defective. And NADPH and cytochrome AA are definitely, these are mitochondrial enzymes which are used for generation of ATP, and they will become defective whenever there is no oxygen. So that is what is the physiology of oxygen delivery from the air to the lungs. I will just have 2-3 more slides on the practical aspects of oxygen use in the NICU. So remember that when we use oxygen in the NICU, fraction of oxygen is different. The oxygen is measured in the fraction of oxygen which we give to the baby and not by the flow of oxygen. So it is amount of concentration of oxygen which you're breathing is important rather than the quantity of oxygen which you're breathing. So always measure the amount of oxygen baby is getting in fraction. And we measure the oxygen the baby has with SpO2, PaO2. And whenever there is no oxygen, baby lands up with lactate levels, high lactate levels, and excess oxygen will lead to more free radicals. How much oxygen when during resuscitation and oxygen support and CPAP and ventilation, we'll discuss that. How do we use the optimized oxygen by using blenders and Venturi applications is what we'll talk. Oxygen is a drug and should be measured. And as I said, measure the oxygen with fraction of oxygen which you're giving to the baby rather than the flow. And dose is titrated to meet the need. And this dose, how much oxygen you give, is based on the hemoglobin saturation, based on the PaO2, based on the lactate levels and base excess, and react to oxygen. If the lactate is going up, you might have to improve the tissue oxygenation. And if there is a lot of free radical, you have to decrease the oxygen concentration, or tissue oxygen levels have to come down. So normal partial pressure is 50 to 70 mm in preterm infants and 60 to 8 mm in the term infants. Normal hemoglobin saturation is 95 to 100 when the baby is breathing room air. When the baby is breathing 21% oxygen, normal saturation is 51 to 95 to 100%. But when the baby is on any respiratory support, even is breathing 21%, but is on HFNC, CPAP, ventilation, the normal saturation is 91 to 95% and not more than 95% for any baby on any oxygen support, any CPAP, any HFNC or ventilation. So start around 60% during resuscitation. The saturation start around 60% at birth and reaches 95% by about 10 minutes. This simple numbers, you have to remember that at birth, the saturation is 60%. By 10 minutes, it becomes 95%. Babies are blue at birth, and it takes about 8 to 10 minutes for babies to become pink. In the fetus, the saturations are 65 to 70%, and PaO2s are 28. So measurement of oxygen is What input is measured by fraction of oxygen. For that, you can use a FiO2 monitor, and the output, what the baby has, is measured with PaO2 and SpO2s, and that you measure with a blood gas or with a pulse oximeter. How much oxygen during resuscitation, during NICU care, during PPHN, pneumothorax, CPAP, HFNC. So the current guideline of resuscitation says that if you are resuscitating a term baby, always resuscitate with 21%. So these are some figures which tells you that normal babies, the saturation keeps on increasing at birth, starts with 65%, but 8 minutes is the time when they become 90 to 95%. So these are some guidelines you can see. You don't aim more than this in normal term healthy babies at birth. So although we are using these targets for babies requiring resuscitation, but we actually don't know what is the actual target for babies who require resuscitation. The guidelines of these first 8 to 10 minutes are based on normal term healthy babies. So in the meta-analysis, it is shown that by using room air for resuscitation, you can decrease the death by 30% when compared to using oxygen. So, but resuscitating preterm babies, 28 to 31 weeks, use 21 to 30% oxygen and try to target saturation of 80 to 85% by 5 minutes. But less than 28 week babies, you start with 30% and go up to target saturation of 80% by 5 minutes. And always use blenders to get these 21 to 30% when you're resuscitating preterm or very low birth weight babies. And 90 to 95% is a target saturation in the right upper limb or pre-rectal is what you are always looking for, and set your alarms with 89 to 96%. Target saturation are 91 to 95%. Alarms are at set 2 less and 2 more than the upper and lower limits. In PPHN, the target saturation are between 92 to 95%. And in BPD again, the target saturations are 92 to 95%. During CPAP, saturation targets are 91 to 95%. Always try to keep FiO2 less than 30%. And if the lung is diseased, try to increase the pressure and decrease the FiO2. If your oxygen requirement is more than 60% while on CPAP, see whether your CPAP is failing or you need to add on surfactant or give mechanical ventilation. During mechanical ventilation, again, saturation requirements are should be between 91 to 95%. Keep your FiO2 less than 60%. And this you can try to decrease by increasing the pressure or MAP. And high FiO2 is damaging to the airways, even if it's not going to the blood because the lungs are diseased, but high FiO2 by itself could be damaging to the airways. So try to keep your FiO2 less than 60% when you are ventilating. So there are 3 major trials which have helped us to derive this 91 to 95% saturations. They are the support trial, the Canadian trial, or the benefit of oxygenation supplement trials. And then from these trials, what we have realized is if you keep the saturation between 85 to 89%, you will get increased mortality and increased NEC. And if you keep between 91 to 95%, NEC and mortality are reduced, but there is some increased chance of ROP. So you should take every possible step to prevent hyperoxia, even when you're keeping the saturation between 91 to 95%. So the current guidelines are based on the current evidence between 95 to 95%, which could slight increase in the risk of ROP, but keep a watch on the ROP and ensure that babies are screened for ROP early so that you don't land up with laser ROPs. So you can use the optimized use by using nasal prongs, use low flows. If you are using hood, please do not use hoods with 2 to 3 liters or more than 5 liters, because this always gives 100%. This is one of the most important reasons for high incidence of ROPs in SNCUs. If you want to use this hood oxygen, have a venturi connected to the hood, and to that you connect oxygen and titrate the oxygen going to the hood by using the venturi. So to summarize, oxygen travels from air to the lungs and from the lungs to the blood, from there to the tissues. The process involves ventilation, perfusion, and diffusions. Ventilation is, you improve the ventilation by improving the concentration of oxygen, that is FiO2, and you can improve the ventilation by increasing the tidal volume or the rate. To get the oxygen from the alveoli to the blood, you increase the volume of exchange or the surface area of exchange. For that, you bring the lung to the FRC. You use mean airway pressure or the pressure to open up the lung, and this will decrease the hypoxia due to VQ mismatch and shunt. And once the blood reaches to the capillaries, it reaches to the tissue because of cardiac output and hemoglobin. And if there is a poor cardiac output, you improve the cardiac output. If hemoglobin is low, you improve the hemoglobin before working on improving the ventilation aspects. And in the tissues, you need to work on improving the oxyhemoglobin curve, shift to the right, so that you can deliver more oxygen to the tissues. So for resuscitation of term infants, use room air. For resuscitation of preterm infants, use saturation targets between 21 to 30%. And in the NICU, saturation target should be always between 90 to 95% for almost all the babies. Thank you.
Thank you very much, sir, for showing us the journey of oxygen from environment to tissues. There are only 4 or 5 questions. I will just read for you. So first one, what Dr. Amol has asked us is that when you are using CPAP, you mentioned that try to keep FiO2 at 0.3 and SIMV 0.6 and HFE at 1. Can you just clarify them that whether we need to keep that much FiO2 only, or we can use a little more or lesser FiO2? Yeah.
As I said, whenever you're going on CPAP, if the lung is a problem, if you want to improve the oxygen, the best way is to open the lung. And the best way to open the lung is using pressure. If you use adequate pressure to open the lung, that is the retractions are diminished, then you can improve the oxygen from 30% to a maximum of 60% on CPAP. But always try to keep your FiO2 less than 30% when you are on CPAP. In ventilation, you try to open the lung using pressure rather than improving the oxygenation by increasing the FiO2. So always try to avoid more than 60% on ventilation. And HFO, the maximum I said is 1, but doesn't mean that you have to use for all babies. Try to keep the oxygen as low as possible. If lung is diseased, you try to open the lung with pressure rather than flooding the lung with more concentration of oxygen.
Second question is about oxygen concentration in the blood. When we mentioned that FiO2 will improve the increase in the oxygen concentration, can you explain them how, while doing the chest compressions, how does the FiO2 100% will help the baby?
So 100% FiO2 will help only when you achieve the good ventilation. So when you achieve the ventilation and when you are pumping, you are making this blood from the alveoli to reach the coronaries. The chest compression is to ensure that the blood is reaching the coronaries so that the heart gets better oxygen and pumping will automatically improve by itself. So did I answer that question correctly, Tejo?
So the main thing is that when we are increasing the FiO2, especially in a low perfusion state, so it will definitely help, as Sir has shown in the table, that once you increase the FiO2, it will improve the oxygen concentration. That's what is the thing. So on the alveolar arterial gradient importance, can you just highlight in 1 or 2 sentences?
So as I said, the blood, whatever PaO2, we have reached a PaO2 of 100 in the alveoli. In the blood, it is 17 newborns. From 100, it is reaching only 70 in the blood. This difference is alveolar to arterial oxygen difference. And this difference is more and more wider in sicker and sicker babies. If you have a RDS baby, from 100, it may become 50. So the difference becomes 50. In a normal healthy baby, it could be PaO2 could be 80. So the difference is only 20. So the more sicker baby, the more will be the difference between the alveolar to the arterial blood. So this is some method to see how severe is the lung disease. You can make out the severity of lung disease by calculating how much is alveolar blood, how much is the blood in the artery. So if you know this difference, you can actually judge the severity of lung disease.
So mainly thing is that serial AA gradient, if you calculate, then it will be of great help for them, for the babies, so that you will be knowing whether it is worsening or improving. Other one is that can we calculate the FiO2 of supplemental oxygen? One thing you have shown is the FiO2 monitors, oxygen concentration checking equipment. Any other formulas you want to tell them?
So I think we will show that when you are doing the supportive